right here that urine cannot leave the bladder, and that will lead to fullness of the bladder and swelling of both kidneys, and this is called a posterior urethral valve, and this can lead to Potter syndrome. This is often detected on prenatal ultrasound. The baby will have a dilated bladder, and both kidneys will be dilated as well. And remember, both kidneys are affected. We talked earlier about some causes of hydronephrosis in one kidney. In this case, you will have hydronephrosis of both kidneys. And when you see that described in a fetus, especially if it's a male fetus, you should think of posterior urethral valves. Another potential cause of Potter syndrome is autosomal recessive polycystic kidney disease. I talk about this in more detail in the video on cystic kidney disorders, but this is the juvenile form of cystic kidney disease that occurs in the fetus or in children. Cysts form in the kidneys and also in the biliary tree. Both kidneys are affected because it's a genetic disease, and if it's severe, it can cause oligohydramnios. If it's less severe, then it may cause renal failure and hypertension in childhood. Horseshoe kidney is a developmental anomaly of the kidneys where the inferior poles of both kidneys fuse. It looks like what's drawn on the screen here. You can see that the bottom or inferior portions of both kidneys are linked together. That's called a horseshoe kidney. When this happens, the kidneys cannot ascend in the pelvis, which they normally do during development, to rise up and settle in the retroperitoneum. They will therefore be lower down in the pelvis. And the reason for this is because they are trapped by the inferior mesenteric artery. It's very high yield to remember this. When the kidneys are fused like this, they get stuck below the inferior mesenteric artery, and therefore they cannot rise up to settle in the retroperitoneum where they're normally found. So in the adult who has horseshoe kidneys, you will find the kidneys lower in the abdomen compared to normal. Most patients are asymptomatic, and the condition is diagnosed when they have a CAT scan or an abdominal imaging procedure for some other reason. This is associated with Turner and Down syndrome. It's more likely to occur in patients with those conditions. And among patients who are symptomatic, it's usually because of vesicoureteral reflux, which I talked about earlier. Remember that anytime the kidneys don't form normally, then the ureters often don't form normally, and that can lead to a setup for reflux. And here's a CAT scan of a patient with a horseshoe kidney. You can see that the kidneys are linked together here across the midline. They're also lower down in the abdomen than where they are normally found. We'll finish by talking about the urachus. The urachus is an embryologic structure that connects the dome of the bladder to the umbilicus, and it should be obliterated at birth and become the medial umbilical ligament. If there is failed or incomplete obliteration at birth, then a number of anomalies can occur. First of all, if there's a persistent connection between the bladder and the umbilicus, then urine can leak from the umbilicus in a newborn baby. Also, sometimes if there's incomplete obliteration, a cyst or a sinus or a diverticulum can form, and these are setups for infections. Here are some drawings of urachal anomalies. This is a patent urachus. The bladder here is still connected to the belly button, and this baby will have urinary drainage from the umbilicus after birth. This is a diverticulum. It's an outgrowth of the bladder from the urachus being left behind. This could potentially become infected. And this is a urachal cyst where there's a little pocket or cavity where the urachus was in utero. It's very high yield to know that urachal remnants can lead to adenocarcinoma of the bladder. This is a very rare form of bladder cancer. Usually the bladder does not develop into adenocarcinoma, but this can occur when a piece of the urachus remains behind. And classically, this will lead to a cancer at the dome of the bladder. So the classic case is an adult with painless hematuria, which is a common presentation of bladder cancer. The tumor is found at the dome of the bladder, and the pathology shows adenocarcinoma. What the question is likely going to ask you about is, where did this come from? And the answer is, it came from the embryologic structure, the urachus. And that concludes our video on renal embryology. Okay, now let's move on to renal pathology. Chapter 16. And one of the first important aspects we're going to talk about is renal agenesis. Remember, agenesis means what? Something did not develop. Now, it's very important to understand during gestation that during the first half of it, that the amniotic fluid is actually made by the fetal membrane, the amnion and chorion. However, during the second half, it's actually made by the kidneys. And in fact, that the amniotic fluid is actually made by the fetal membrane, the amnion and chorion. However, during the second half, it's actually made by the kidneys. And in fact, the infant will aspirate the fluid for maturation of the lung. It's very important when we talk about this disease. So what happens? If you have renal agenesis, you don't get the amniotic fluid, you get so-called what?
oligohydramnios, decrease in fluid, and then what happens? You get compression of the infant. The nose is going to be smashed in. They're going to have club feet, breech presentation at birth. However, if these patients die, they will die from pulmonary hypoplasia because, again, they do need the amniotic fluid for maturation of the lungs. Now, this next slide, the next important thing is horseshoe-shaped kidney. Now, the key with this one is, again, it's going to be fusion at the lower poles. However, remember what? Kidney function is normal. What's going to put in the step, though, is we have renal failure, azotemia, some type of abnormality. But the key is for that normal renal function. That's what you want to remember. Now, for your cystic diseases, it's very important that you want to begin compare and contrast the adult versus the infantile type of polycystic kidney disease. Now, for the infantile type, very important, there's autosomal recessive, and in general, when you have Mendelian inheritance, if it's a child, always think what? Autosomal recessive. If it's an adult, think autosomal dominant. Okay. Very important that it's going to be an infant or child. It's going to be bilateral enlargement of the kidneys. Okay. And very important that the surface of the kidneys are smooth. Why? Very important that the cysts arise from the collecting ducts, which are in the medulla. Very important to have a smooth surface. Okay. Also note that they have multiple cysts in the liver. Okay, that also can be seen as well. So now let's talk about the adult type. Okay, so again, it's going to be an adult. It's going to be bilateral enlargement. And now the surface of the kidney are going to be irregular. Why? Because now the cysts are rising from the proximal and convoluted tubules. So you get irregularity of the surface. Also, don't forget, this disease is associated with aneurysms seen in the circle of Willis. Why? The key is this protein called polycystin 1 found on chromosome 16. Now, you know the STEP exam loves chromosome. Everything's a molecular layer. So you got to know chromosome 16. And this protein is abnormal. Because of the abnormality of the protein, what happens is the wall of the blood vessel in the circle of Willis become weak, allowing aneurysmal dilatation. Very important correlation to make for the STEP. Now, these patients, again, will have bilaterally enlarged kidneys, irregular surface, and they're going to have problems with hypertension and hematuria. So those are things you want to remember, very important for your clinical correlation. And again, like I said, bilaterally enlarged and bulging cysts. Okay? And again, your aneurysms are very important for the STEP exam. Okay? Wonderful picture they may show you. Again, notice how the cysts are very regular, large, and you have a irregular surface of the kidneys. Now for this next slide, renal dysplasia, sometimes called cystic renal dysplasia, very important. It's also seen in infants, just like the autosomal recessive polycystic kidney disease. The difference is, number one, is unilateral. So one way to differentiate cystic renal dysplasia from the infantile polycystic kidney disease is it's going to be unilateral enlargement if it is cystic renal dysplasia. That's number one. Number two, because the tissue is primitive, the key thing is going to be this irregular or immature cartilage seen microscopically. So the key is they're going to give you a biopsy, and it's going to show immature cartilage. Very important for cystic renal dysplasia. Now, for your medullary sponge, the main thing for that one is the patient has cysts, but again, the patient is what? Asymptomatic. This is something we see incidentally when the patient has an autopsy or for some other reason. Very important that the medullary sponge kidney is typically asymptomatic. In patients. let's move on to important glomerular diseases. Now, they love the contrast of different types, so you can differentiate them. Also, too, there are a lot of glomerular nephropathy, a lot of diseases associated with nephritic and nephrotic, but sometimes the name can actually help you determine which type it is. So everything's in the name, right? Everybody's got a name. So now comparing the two, with nephritic syndrome, the key thing is you have so-called what? Glomerular cell proliferation. So either cells in the glomerulus are proliferating or cells are coming in like inflammatory cells. Why is that a big deal? Well, number one, you get compression of the capillaries. That's not good because the JG complex sees that as what? Decrease in blood flow. And the kidney, I'm telling you, the kidney hates low blood flow. What happens? Renin is increased, and therefore you get vasoconstriction that leads to what? Hypertension. That's one problem with nephritic syndrome. The other problem is this: because you're compressing the capillaries, now you're going to damage syndrome. The other problem is this: because you're compressing the capillaries, now you're going to damage the wall, and that leads to red cells leaking out, giving you hematuria. So the two major clinical manifestations of nephritic syndrome are what? Hypertension and hematuria that you can see here. Okay? Now, the red cell cast, very important too, means this: as the red cells leak out of the glomeruli, they go into the tubules and get trapped, and they make a cast mold of the lumen. Pressure builds up behind it, it's forced out, and you can actually see these casts inside the urine on the urinalysis. So very important, if you see a red cell cast on the exam, you think nephritic syndrome. I'm going to talk about the major one that you typically see on the step. Now, also notice you will get some proteinuria, but very small amount, okay, and azotemia as well. Now, with nephrotic syndrome, the key thing is you have a so-called what? Leaky basement membrane, allowing protein, mainly what? Albumin, to leak out. How does that occur? Typically what happens is you get a deposit inside the basement membrane. Why is that important? Now remember, going back to normal anatomy, etc., that the basement membrane has the what? Overall negative charge. So does albumin. So that's how the albumin stays inside, because same charges do what? They reflect each other. What happens is when you get deposits in the basement membrane, it changes the charge, allowing albumin to leak out. Okay? So these patients, as you see here, have severe proteinuria. So therefore, they're going to present with what? Peripheral edema. That's the key thing, peripheral edema. And sometimes, if the edema is very severe, you could for all the loss of protein, so he throws out lipids trying to compensate. Now, of course, obviously it doesn't work. But again, trying to compensate it, you get the lipiduria. So very important that if it's nephrotic, you're going to have severe proteinuria, peripheral edema, as well as you may see lipiduria as well. Now, very important, if you look down here, you can see how we can actually examine the kidney. And we love to look at it by light microscope, immunofluorescence, and electron microscopy. So sometimes they'll actually either describe it or they're going to give you a picture of how it looks. So when we look at these different diseases, we're going to go through it and make sure you understand what you're supposed to see when you talk about these different types of diseases. Okay, now this picture is an overall view of an EM of a glomerulus. And what you can see here, this is your basement membrane going along down here. Okay, these are the podocytes coming off of your visceral epithelial cell. Give rise to them there. This is your capillary lumen. You can see here, red blood cell. Okay, so again, this is your overall picture. They will show you that. Typically on the exam, they'll give you a high magnification so you can really see the deposits and where they're located inside the basement membrane, etc. But this is, again, just kind of like an overall view of the EM. Now let's move on and talk about some of the important glomerulonephropathies that they love to ask on the step. This one, they love the acute post-streptococcal glomerulonephritis. Very important that this one is typically going to be a child, and they're going to have a history of sore throat. Kind of like what other disease we talked about before. That's right, rheumatic heart disease. Remember that disease? Again, caused by your group A beta hemolytic streptococcal infection. It's the same organism causes this, the same antigen antibody complexes, but now instead of depositing in the heart, what are we going to do? We're going to deposit inside the kidney. In the glomerulus. So it's very important. We're going to talk about that one. Goodpasture syndrome, we're going to talk about typically seen in young males. RPGN, very important as far as causing rapid deterioration of your glomerular function. IgA is very important because of recurrent hematuria. We'll talk about that. Now, membranoproliferative, we're going to as well talk about. If you look at that one, notice how it says membrano and proliferative. Now, it's involved membrane. What does that mean? You're talking about nephrotic syndrome, right? Leaky basement membrane. Proliferation is seen with what? Nephritic syndrome. So membranoproliferative, again, the name tells you it's one of the two major diseases that can be what? Both nephritic and nephrotic. So that's why I said sometimes the name can help you with what type of disease you're dealing with. And then we'll talk about outports, typically seen in kids. And the key thing with this one is going to be deafness and a problem with the basement membrane. Okay. Now, like I said, with acute post-strep, very important. Typically going to be a child, history of sore throat. And then all of a sudden, the mother's going to notice that their eyes are going to be kind of puffy, and she may also notice that the patient's urine gets a little dark. Okay, she's going to bring the patient to the pediatrician. You're going to work the patient up, and the patient's going to have not only the hematuria, but also be hypertensive. Why? Because again, this is a nephritic disease. Very important. So again, what happens is this organism, the complexes, will form or deposit inside the glomerulus. Again, very important. Remember, it's what? Cross reaction with the M protein of the organism, which is a part of the capsule. So you can ask that as a micro question, going back to that. Okay. So because of that, you get the infiltration of what? The neutrophils. Remember, neutrophils attack bacteria, and that's what causes the proliferation of the glomerulus, leading to nephritic syndrome. Okay. Now, very important that with your laboratory studies, again, ASO, or so-called anti-streptolysin O titers, will be elevated. Very important. Sometimes they'll do hyaluronidase, DNase also can be elevated as well, but ASO is a major thing they typically will ask you about. Okay. Now, by light microscope, very important. What you're going to see are the neutrophils infiltrating into glomerulus. Okay. Very important though, on EM, you will see what? So-called subepithelial humps, which means the deposits will form on the top of the membrane underneath the epithelial cell that gives rise to the podocyte. So it's on top of the membrane, but it's not in it. And that's why it's nephritic syndrome versus nephrotic. See, if the deposit was in the membrane, then you'd have a nephrotic component. But it's mainly nephritic because it sits on top and not in. That's very important. And like I said, it's very important. You want to see red cell casts when you do your analysis. This is a classic disease that they give that has the red cell cast. Okay, very important that typical deposits are going to be IgG and C3, okay? And you see in most of your diseases, IgG and C3 are seen in most of them. So an exam asks you just can't remember what the type of deposit is, go with IgG and C3. Again, here's your subepithelial deposits, sometimes called humps. Now, very important, if they do immunofluorescence, which lights up immunoglobulins and antibodies, you're typically going to have what is so-called granular, or may just be described as lumpy bumpy, right? It's not going to be linear, because remember what? Good pastures is the main one that's going to be linear. So all the other ones, if they ask you, what should the pattern be? You're going to say granular or lumpy bumpy. Now, like I said, very important that the prognosis, typically 95% recovery, very important. Now, if it does get bad, that RPGN is going to be one of your major diseases you worry about, and we'll get to that in just a second. Now, for good pastures, very important that number one, this is a what? Type 2 hypersensitivity. Don't forget that, because sometimes they will ask you that on the step exam as well. Also, that these patients are going to typically be a young male. That's unusual because this is a what? An autoimmune disease. And typically they're seen in females. But this patient is going to be a young male, and he's going to present with what? Hematuria and hemoptysis, classic presentation. Typically have the hemoptysis first, followed by hematuria. Now, again, for the step exam, for correlation, compare, and contrast, patients with what? Wegener's granulomatosis also have hematuria and hemoptysis. However, patients with Wegener's have what? They have sinusitis. Why? Because Wegener's involves the upper and lower respiratory tract. Good pastures is only lower. So on the exam, if the patient has hematuria, hemoptysis, and sinusitis, it's got to be Wegener's, not good pastures. Okay? Now the key with this one is, as you see here, antibodies to the basal membranes found in the lungs and the kidney. Okay, that's very important. Like I said, it's going to typically be a young male, 20s, 30s, or 40s. Very important that this disease does not do well in these patients. They typically have to have dialysis and renal transplant, may be a sequela of this. Very important that good pastures also is a type of your rapidly progressive glomerulonephritis, which we're going to talk about in just a second. Now, very important that we look at good pastures on EM. Like I said, now you're going to see what? A linear pattern of immunofluorescence. Very important. If you see that on a test, look for good pastures. Again, because of the antibody, the way they deposit in the basement membrane, again, in the glomerulus. Very important. Okay? As you can see here, it may lead to rapidly progressive glomerulonephritis, which can lead to renal failure. So be aware of that as well. Now, for your RPGN, very important here, you get a so-called crescent or crescent shape appearance of the glomerulus. What's happening? You're getting proliferation of the parietal cells of Bowman's capsule. Very important. So they proliferate and they form a crescent shape, and what they do, they compress the glomerulus. So again, this is going to be what? It's going to be a nephritic syndrome because you're getting proliferation of the cells from the glomerulus. Very important. Okay, so these patients go into renal failure. Now, if you look at it, there's a whole list of things that can be associated with it. See here, good pastures can lead to it. Burgers, SLE, acute post-strep, vasculitis. Now, look at the other forms of glomerulonephritis. Guess what? They're all associated with nephritic syndrome. So if you go back and look at RPGN, there's a type 1, type 2, type 3. Don't try to learn those different types. Just remember, all the nephritic syndromes can lead to RPGN. You never go wrong with that. Okay? So like I said here, crescent formation from Bowman space. Very important. May have granular or linear deposits. Of course, if it's good pastures, secondary good pastures, that can give you a linear deposits. But all the other ones, of course, are going to be what? They're going to be granular deposits. Very important. Okay, and again, again, these patients typically going to have poor renal function and can lead to end-stage renal disease. That's what you want to remember for RPGN. Now, for IgA nephropathy or Buerger's, and don't confuse this Buerger's with what? Your thromboangiitis obliterans, Buerger's disease in the blood vessels. Remember, that Buerger's is spelled with a U. Okay, don't forget that one's spelled with a U. Now, for this one, the key is, number one, the most common cause of recurrent hematuria worldwide. Very important. Okay, now, so why do they have hematuria? Well, you see here, the name is IgA. What do you remember IgA? It is a secretory antibody, correct? So what happens? This patient is going to get an infection either of the GI tract, okay, the urinary tract, or the pulmonary tract. They get the infection, IgA is produced. IgA deposits in the kidney, giving you this manifestation, right? The infection goes away, the hematuria goes away. You get the infection again, the hematuria comes back. So that's going to be the key with this one. The patient with a history of gastritis or pneumonitis or something like that, and they keep getting hematuria. Now, very important. It's an antibody. And typically with antibody production going into the kidney, you get involved in the basal membrane and get nephrotic syndrome. However, here, the antibodies mainly deposit where? In the mesangium, causing proliferation, leading to nephritic syndrome. That's the key. So antibodies are produced, they mainly deposit in the mesangium, leading to proliferation, which gives you your nephritic syndrome. That's what you want to remember, okay? See here again, it's typically males. Very important is association with celiac sprue. Why? Celiac sprue also associated with IgA. And this Henoch-Schönlein purpura. They love that. Typically going to be a child of distension, purpura on the skin, again, with the IgA. And they also get vasculitis, typically of small blood vessel. Very important correlation to make. And again, very important, mesangial deposits of IgA. Sometimes you get C3, but it's mainly IgA is what they ask you about on the STEP exam. So again, be aware of that. Now, like I said before, proliferative disorder is telling you what? That it's both nephritic and nephrotic. So let's talk about the different types and manifestations you can see with this disorder. Now, it's broken down here, you can see, into type 1 and type 2. So we're going to compare and contrast two different types. Again, you see here, it can be nephritic, nephrotic, or mixed, okay? Now, typically it's secondary to some type of infection. Either infection or cancer is what they're going to give you on the exam. Hepatitis is, of course, the classical one that you can see here. Sometimes they'll give you HIV, okay? Malignancy, CLL is a good one. Of course, that's going to be an elderly patient, okay? Now, as far as the laboratory findings, it's very important that C3 will be very low, particularly with type 2, dense deposit disease, as well as this nephritic factor, also associated with type 2, which they love to talk about because the nephritic factor does what? It activates the alternative complement pathway, leading to the increase in C3. They love that on the STEP. So, very important. Again, because of these deposits, you get proliferation of the Zannu cells, okay, that can lead to your nephritic portion. And we look at the two different types. One type is called so-called tram track. And what happens is the basement membrane splits because of the Zannu proliferation. Okay, so that gives you the so-called tram track or splitting of the basement membrane. That gives you a duplication. So be aware of that. Okay. With your type 2, the key is you get the so-called ribbon-like deposits of C3 in the basement membrane, which is why type 2 is also called what? Dense deposit disease, because you're getting deposits, but they're a lot thicker than you typically get with other types of nephritic or nephrotic syndrome. So be aware of that. So very important that type 1 is tram track, splitting of the basement membrane. Type 2, dense deposit disease, again associated with what? Nephritic factor and activation of the alternative complement pathway, giving you the elaboration of C3, which deposits in the basement membrane, again, ribbon-like, right? Ribbon-like. Again, there's your tram track you can see there. Now, for all parts, the key thing with this one is, they're going to ask you about, it's going to be a child, and the patient is going to be with hearing. That's going to be the key thing. It's X-linked, so of course what? It's going to be a male, right? So it's going to be a male child. He's going to have these problems hearing, and then you're going to work the patient up and notice he's got renal dysfunction. That's going to be the key. So you're going to have hematuria, that you can see here. And the key thing, this is what they're going to ask you on the STEP, is the M and the so-called splitting of the lamina densa on M. That is key. Okay, so they love to ask that question on your STEP exam. But again, just remember, all that stuff is down there. But the key thing is male child, hearing problems, and again, you're going to have the renal manifestations, and then look for the splitting of the lamina densa. Okay. Now, for membranous glomerulonephropathy, so again, it's called membranous. What does that mean to you? Option number one, it must be a nephrotic syndrome because you have involvement of the basement membrane. That's the key, right? So very important to see here, most common cause of nephrotic syndrome. And again, like I've said, anytime you read something, it's the most common, typically something you need to know for the step. Okay, very important. Okay, the causes for the membranous glomerulonephritis, which you can see here. D is for drugs, right, like penicillamine. I is for infection. Again, hepatitis. They love hepatitis on the step. I don't know why. Um, um, S is for lupus. Typically, systemic diseases, but lupus is the major one they're going to ask you about. And then C is for what? For cancer. You see here, lung and colon. Okay. Now, very important that now you're getting a very thick basement membrane. It's going to be diffusely thick in the glomerulus, and you actually can see that on light microscope. Okay, you can see that right there. Right. However, a silver stain is one of the stains we like to look at, and the silver stain actually will light up the basement membrane. Because of the way it deposits, the deposits go into the basement membrane. What you're going to see, these so-called spikes, or sometimes described as hair-on-end appearance of the basement membrane on silver stain. Very important. C3 again, the major deposit. I said on the exam, you can't remember, go with IgG and C3. Okay? Now, very important that when they deposit inside the membranes, you get the so-called spike and dome appearance on EM. Spike and dome. Now, what does that mean? The spike actually is the normal basement membrane, and the dome is the deposit. Okay, so the spike is a normal basement membrane, and the dome is the deposit. So spike and dome, spike and dome. So it kind of looks like this. You see, or sometimes described as, so again, like I said on the exam, you can't remember, go with IgG and C3 dome. The dome is the deposit. So spike and dome, spike and dome. So it kind of looks like this. You see a spike, then get a dome, spike, then a dome, spike, then a dome, spike, and then a dome. Classic appearance, as you can see. And of course, some of you might remember, spike and dome sounds familiar. Well, again, going back to neuro, remember, petit mal seizures on EEG have a spike and dome appearance. So that way, and nothing to do with this, of course, don't get me wrong, but the point is, that's where you might have heard about spike and dome before, okay? So, very important that, again, you get these deposits and giving you the spike and dome appearance. All right. Now, minimal change, very important. Now, this one, again, is going to be seen in children. It's the most common, okay, type of nephrotic syndrome seen in children. Why is it called minimal change? Why? Because by light microscope, the glomerulus looks normal, okay? Sometimes also called nil disease, because nil means nothing, looks normal. And also called what? Lipoid nephrosis. Why? Because we said way back when, again, because of the loss of protein, what happens? That the liver's going to try to compensate for that by throwing out a lot of lipids. So sometimes they will call this lipoid nephrosis. So be aware of these different names. Okay? As you can see here, lipoid nephrosis and nil disease. Now, very important clinically, typically the patient was going to have history of having immunization. Protein, what happens? That the liver is going to try to compensate. Now, very important clinically, typically the patient was going to have history of having immunization. After immunization, that's when they're going to present with the peripheral edema, and then you're going to find that they have what? Heavy proteinuria. So that is very important for the step exam, because they will put that on the step. Okay, now, the kids, like I said, by light microscope, you don't see anything. Okay, and this disorder is a little different from the other nephrotic syndromes, because you're actually not seeing true deposits in the basement membrane. What are you going to see? Well, you have to go to EM, and what you're going to see is so-called effacement of the podocytes. Now, we used to say fusion. We don't say fusion anymore. Now we say so-called effacement of the podocytes, and that's what's allowing the protein to leak out. So that's what you want to remember for the step exam. So you must do EM to make a diagnosis, okay? So it's not done by light microscope, it's not done by immunofluorescence. You've got to do EM, because they're going to ask you how you're going to make a diagnosis. Now, very important that the treatment, the prognosis is good, and treatment is steroids. That's very important when we compare this to focal segmental glomerulonephritis. So very important, again, minimal change, it's going to be a child, immunization, nephrotic syndrome, and very good recurrence with corticosteroids. With focal segmental, okay, number one, why do we call it focal segmental? What happens is if you do a biopsy, okay, and you look at the glomerulus, so it's called focal because not all of the glomeruli are involved. Okay, so one's involved, 3 or 4 may be normal, another was involved. Okay, called segmental because of the one that is involved, only a segment of it is involved. Okay, that's very important. Why? Because with a small little core needle biopsy, you might miss one that's involved. So you do a biopsy, and it looks like what? It can look like minimal change. Okay, very important. Why? Because these patients with focal segmental do not respond to steroids. That's why it's very important to make that difference clinically. Okay, so again, if it's minimal change, they respond very well to steroids. If it's focal segmental, they do not. Okay, it's very important to note that focal segmental is classically associated with IV drug abusers and AIDS patients. So that's the typical presentation they will give you on the step: IV drug abusers and AIDS patients. And again, it is a nephrotic syndrome, so they're going to present with what? Peripheral edema. But again, do not forget, these patients do not respond to steroids. And of course, if the patient got AIDS, you don't want to give them steroids because you make their disease even worse, right? And then, of course, next thing you know, you'll be in the the courtroom, raising your right hand like this, saying, I promise to tell the truth, the whole truth, and nothing but the truth, because I did a bad thing. But you won't do that. I know you won't. Okay? Now, like I said, very important that you have the sclerosis, hyalinization of the glomeruli. Okay? And like I said, very important, poor response to steroid. That's very important. They will ask you that on the step. Poor response to steroid. And because the prognosis is not good, lead to renal transplantation. Okay, so that's what you will remember for the step. Now, for our secondary glomerulonephritis, the two major ones that we'll talk about are going to be diabetes and lupus. Now, Doc will go into more detail when we do the pancreas. And the endocrine function. However, though, it is important to remember that diabetes does cause nephrotic syndrome. I will be aware of that. Okay, and that we're going to talk about nodular glomerulosclerosis is how we make a diagnosis. Sometimes also called Chemist-Wilson's disease. They love that. That's actually pathognomonic for diabetes. But again, we'll revisit that when we do the endocrine pancreas. Now, for lupus, very important that lupus also is the other major disease that can be both what? Nephritic and nephrotic, that you learned about again with immunopath. Okay, again, hematuria, but again, with your nephrotic disease, of course, they're going to get what? Edema, peripheral edema, and again, severe loss of protein. Now, I will tell you this. With lupus, if it's nephrotic syndrome, sometimes you see a term called wire loop deformity, which means what? The basal membrane is so thick, it looks like a loop of wire on light microscope, okay? The other thing you might see on the step exam is the so-called full house pattern. Like I said before, with the other diseases, you mainly get deposits of C3, IgG. With lupus, everything can deposit. It's like a full house, kings over jacks. Okay, so the point is, see 1, 2, 3, 4, all the 9, all the different antibodies, IgM, IgE, IgA, they all can deposit with lupus. Full house pattern. Don't forget that. And don't forget lupus deposits. Annual, subepithelial, or subendothelial. However, classically with lupus, if they ask you on the step, you say what? They're mainly subendothelial. Okay, so again, for lupus, the deposits are mainly or classically subendothelial. Okay, and for the nephritic portion of lupus, I'll mention this because they like to ask this on the step. There are different or 5 different classes of renal lesions with lupus. Okay, the major one the most common one is type 4, called what? Diffuse proliferative glomerulonephritis. So that's the one you got to know. I would try to learn all those different classes, but you got to know type 4 and diffuse proliferative glomerulonephritis. Why? It's the most common type and has the worst prognosis. Gives you the nephritic portion of the disease. Okay. This actually is a picture you can see here of the glomerulosclerosis seen with patients with diabetes. You can see the nodules here. And I will mention to you now that these nodules are PAS positive. Okay. Now, we like to do stains and pathology. Why? To help us differentiate. Okay. Different stages. Now, however, as you notice, as you go through the different organ diseases, that what? PAS is the most common one that comes up being positive in different disorders. So I tell students on the step, if they give you a list of stains and they ask you which stain to pick, and you just cannot remember, go with PAS. Because you're going to see as we go throughout the rest of these different organ systems how PAS keeps coming up. Now, for your chronic glomerulonephritis, the key thing is that these patients are going to have chronic renal failure. Okay, they're going to have renal failure, as you can see here, uremia, ultimate death, and the key is that many different types of disease. Is like acute post-strep, proliferative, lupus, all of them can lead to this. So think of chronic glomerulonephritis as end-stage renal disease, okay? Think of this as an end-stage renal disease. They're going to have problems with calcium metabolism, so these patients can get secondary hyperparathyroidism secondary to this. And very important that the kidneys are going to be small and shrunken and have a granular surface. Small, shrunken, granular surface. Now, again, for a differential, if you see that on the test, if a patient presents with small, shrunken kidneys with a granular surface, it's either going to be chronic glomerulonephritis or benign nephrosclerosis, okay, associated with either diabetes or hypertension. What happens is the blood vessels become colonized, low blood flow, you get atrophy, and the kidney contracts. But like I said, very important with chronic glomerulonephritis, think of end-stage kidney disease, and that the patients typically, again, need dialysis and renal transplant.
module on glomerular disease principles. So before we can talk about diseases of the glomerulus, we need to talk about what the glomerulus is supposed to do under normal conditions. So the glomerulus's job is to allow ultrafiltrate into Bowman space. So what is ultrafiltrate? That's water, electrolyte, glucose, and amino acids, all the things that the kidney wants to allow into the nephron so that they can then control how much it absorbs or excretes. Importantly, though, the glomerulus wants to prevent the filtration of most proteins and prevent the filtration of red blood cells. So when you have a sick glomerulus, you get protein and blood in the urine, and that's called proteinuria and hematuria. In order for things to move from the glomerular capillary into Bowman space, they have to pass through the glomerular filtration barrier. And it's very important that you understand the three components of the filtration barrier because the pathology in all these diseases involves these three components. So if we draw some blood moving through the capillary here, if it wants to send parts of the blood into Bowman space, it must go this way through all three of these layers. So the first layer is the endothelium of the capillary. The second layer is the capillary basement membrane. And then the third layer are these cells called podocytes. And it's very important to know that the podocytes are also called the epithelium. So you will hear in glomerular diseases about problems with the endothelium, and that's the capillary endothelium, and the epithelium. The epithelium means the podocytes on the other side of the basement membrane from the capillary. So let's talk about each of these components of the filtration barrier in more detail. So the capillary endothelium is fenestrated, and that means it has small openings, and only small molecules about 40 nanometers in size can pass through. This is going to repel red cells, white cells, and platelets, and it's the first barrier to filtration. So essentially the capillary endothelium is going to keep out most molecules inside the plasma. The next layer is the basement membrane, and one of the most important features of this layer is that it is made up of negatively charged molecules. It contains type 4 collagen that is wrapped in a substance called heparan sulfate, which is negatively charged. As a result, the basement membrane repels negatively charged molecules like albumin. It also serves as a size barrier and only allows small molecules to pass through. And finally, the third barrier are the podocytes, which, as I said before, are called epithelial cells. And they have these long processes called foot processes that wrap around the capillaries. And the slits between the foot processes act as a filter. And this is a further size barrier, only allowing very small 4 nanometer or so molecules to get through. So albumin is the major protein in the blood. Recall that it's responsible for most of the oncotic pressure of the plasma. It's a small protein, about 3.6 nanometers. Size. So it can fit through all the size barriers. The reason it can't get the filtration barrier is because it's negatively charged and it's repelled by the glomerular basement membrane. I made this point before, but I'm just mentioning it again because albumin getting into the urine is responsible for much of the pathology in glomerular diseases. So now let's talk about the different types of things that happen to patients with glomerular diseases. On a fundamental level, all these diseases cause breakdown of the filtration barrier. So things that shouldn't be in the urine get there, like red cells and protein, especially albumin. So hematuria, red blood cells in the urine, are a common finding in many forms of glomerular disease, and hematuria is detected by urinalysis. There are 2 urine tests that are used to identify the presence of red cells in the urine. The first one is the urine dipstick test. a standard urine dipstick strip and dipping it in a sample of urine, it will detect a number of substances in the urine, including the presence of heme. Heme has peroxidase activity, will react with the strip, so the dipstick test will be heme positive if there is either hemoglobin or myoglobin in the urine. Usually when this test is positive, it means there's blood in the urine. However, it can also be positive in rhabdomyolysis when there is myoglobin in the urine. The second way to detect red cells in the urine is by microscopy. This involves taking a sample of urine and looking at it under the microscope, and red blood cells can be directly. It has many, many causes, and in fact, glomerular diseases are incredibly rare. We call hematuria gross when the urine changes color, and then we call it microscopic when the urine has normal color, but if you look at it under the microscope with urinalysis, you can see evidence of red cells. Hematuria can occur after exercise in normal kidneys. We don't know why this happens, but some patients, when they exercise strenuously, will develop hematuria. And very common causes of hematuria are urinary tract infections, and feared cause of hematuria is bladder cancer. And then, as I said before, glomerular diseases are very rare. But hematuria from glomerular disease is usually easy to identify because patients will have red cell cast, which we'll talk about in a minute, and also protein in the urine. So the from the glomerulus are red cell casts. So if you have a glomerulus here and red cells are able to squeeze through that filtration barrier because of disease, they will then be pushed into the nephron. They will all get bunched up together inside the nephron, and this will form a cast of the red cells. So down here on the right is a picture of a red cell cast under the microscope, and as I said before, this is the hallmark of glomerular bleeding. Other things you may see are dysmorphic red blood cells. These are red blood cells that have an abnormal shape, and just like the mechanism of cast, this happens because you're squeezing them through the filtration barrier in the nephron. You can also see acanthocytes. These are red blood cells that have a spiked cell membrane, so instead of being a nice circle, they sort of have a spiky cell membrane looking sort of something like this. And then in addition to the red cell findings, people with glomerular bleeding often have proteinuria. They can describe their urine as having a red, smoky brown color or Coca-Cola color. And importantly, clots are generally not seen. People who have clots in their urine have heavy bleeding. That's usually from the bladder. It's usually seen with kidney stones or bladder tumors. So proteinuria is another hallmark of glomerular disease, and there's a couple of ways we can diagnose proteinuria. The first is, again, to use that urine dipstick. It has squares on it that will change color, indicating the amount of protein. And it primarily detects albumin, which is good for glomerular disease, but you should know this because in other pathology where the protein involved is not albumin, the urine dipstick is not so good at picking it up. We describe the urine dipstick proteinuria as 1+, 2+, 3+, or 4+ to say how much protein there is. So glomerular diseases often have 4+ protein, meaning there's a lot of protein in the urine. And the problem with the urine dipstick is it's affected by urine concentration. So if you're dehydrated, the concentration of the urine can go up and you can get a false positive. Another way to test for proteinuria is to do something called the urine protein to creatinine ratio. This is also called a spot urine. So you take the first or second morning urine sample after avoiding exercise and you test for the amount of protein and creatinine in the sample. And the normal ratio is less than 0.2, and this is less influenced by hydration status, so some people find it to be more accurate. Then the ultimate way to measure protein in the urine is protein excretion by the kidneys. It gives you an actual number of grams per day of protein excretion, and normal the nephrotic syndrome. This is where patients have massive other mechanism. The loss of plasmic oncotic pressure leads to a reduction in extracellular volume and a reduction in glomerular filtration rate. This is going to ramp up the renin angiotensin aldosterone system tension. So that is also going to contribute to the edema. There are two mechanisms by which you get edema in the nephrotic syndrome. Now, when you begin to lose all that albumin, the liver tries to become active to replace it, but it can't keep up with the losses. What you're going to see in the patient's yell, and that's seen in because you're losing protein syndrome is a hypercoagulable state. And they'd love to ask you on your boards about patients with nephrotic syndrome who then get pulmonary embolisms. And the mechanism is the loss of antithrombin 3 in the urine. And then lastly, other proteins that you lose in the urine are immunoglobulins, and this predisposes patients to infections. So some patients with nephrotic syndrome are at increased risk of infections. Make sure you understand this map and how all these things work together. Let me give you a little more detail about the urine in patients with nephrotic syndrome. You may see lipids in the urine. Talking also about where the patient with a filtration to nerve allergy, but it's actually nephrotic syndrome. But damage, the glomerular filtration rate begins to fall. These patients will have renal failure. There will be red cells in the urine. They will be those dysmorphic number. Nephritic syndrome usually has less than 3.5 and has more than 3.5. So here's our map of the sequence of events in nephritic syndrome, and let's go through it in detail just like we did for nephrotic syndrome. So you lose the filtration barrier, and as a result, cells spill into the urine, and you get all these findings over here, dysmorphic red cells and CAS. In addition, the GFR begins to fall. This means that the BUN and creatinine levels will rise. It also means that patients may have oliguria. They'll have decreased urine production. Because the GFR falls, the hydrostatic pressure inside the vasculature goes up. So patients with nephritic syndrome will have hypertension, and that hydrostatic pressure will drive fluid into the extracellular space, and you will get edema. Another mechanism by which you get edema is that there's proteinuria from the protein loss in the urine. So therefore you lose the oncotic pressure, and this also triggers edema. So there's two ways you get edema in nephritic syndrome. Just like with nephrotic syndrome, make sure you understand this map because you're commonly tested on the mechanisms by which the symptoms develop in nephritic syndrome. So the classic presentation of a patient with nephritic syndrome is for a patient to complain of dark urine from all those red cells. They'll complain of swelling and edema. They will often have fatigue as a symptom of the uremia, and then they'll have proteinuria, but it's less than 3.5 grams per day. The last thing I'm going to discuss in this module are different techniques of microscopy. So most glomerular diseases are diagnosed by doing a kidney biopsy. And once you biopsy the kidney, you have to look at it under the microscope to figure out which disease you have. And there are three techniques we use to discern the different glomerular diseases. The first is light microscopy, and that simply means using a basic stain and looking at it under the light microscope. And you can see magnifications up to 2000x this way. And here I've shown a picture of a normal glomerulus. The second thing you can do is treat the sample with antibodies that light up under immunofluorescence. And this is a way to look for specific proteins or antigens. This is called staining. And this is a picture here of a glomerulus that's been stained with immunofluorescence. Then the last thing you can do is use something called an electron microscope. So an electron microscope uses electrons instead of photons to take very high magnification pictures of structures. These can take pictures up to 10 million times what you normally see with your eye. And this is the way we look at very detailed structures like basement membranes and podocytes. And this is a picture up here of a normal basement membrane and a set of podocytes. So make sure you understand the difference. So that Hello, everyone, and welcome to our module on the nephritic syndrome. Let's start by reviewing the pathophysiology of the nephritic syndrome. All of the causes of nephritic syndrome, as we will see in this video, lead to inflammation of the glomeruli. That's called nephritis, and that's how the syndrome gets its name, nephritic syndrome. When there is inflammation in the glomeruli, the filtration barrier to red cells and protein is lost. As a result, red cells spill into the urine, and characteristic findings are dysmorphic red blood cells and red blood cell CAS. I discussed these findings in more detail in the video on glomerular disease principles. In addition, because the filtration barrier is lost from inflammation, there will be protein in the urine as well. Now, because the glomeruli are doing their job, and therefore they are not filled, such as a rise in the BUN and creatinine and a decreased production of urine, which is called oliguria. In addition, because less plasma is being filtered by the glomeruli, there's a rise in the hydrostatic pressure. This leads to hypertension. It also leads to capillary leak and edema, which are hallmarks of the nephritic syndrome. The protein loss in the urine also can lower the plasma oncotic pressure, and that also contributes to the edema as well. So the classic presentation is for a patient to develop dark urine from red cells in the urine, swelling and edema. There are often signs of fatigue. This is due to uremia from the renal failure. And there will be proteinuria, but importantly, the proteinuria is less than 3.5 grams per day. More than 3.5 grams per day is seen in the nephrotic syndrome. In the nephritic syndrome, there is less proteinuria, and that's because the glomeruli are inflamed. There's a fall in the glomerular filtration rate, and therefore less protein is lost in the urine compared with the nephrotic syndrome. Before we get into specific causes of the nephritic syndrome, let me review a very important general point about the site of glomerular injury and how that process leads to either the nephritic or nephrotic syndrome.
It's time to go. Goodbye. Comfortable.